Well, today's speaker has taken our department by storm since joining us about just a year and 2 months ago. Brian Daly is the vice chair for public sector psychiatry, he's an associate professor, and he's the chief medical officer of Community Healthlink, and got his MD at University of Rochester. I have a kid who went there, so we call it U of R, but probably for here I should say University of Rochester. Did his psychiatry residency at Brown, did forensic psychiatry at, I'm in Ohio, and so I'd say U of M, but it was University of Michigan, right? His career has been all about public sector psychiatry leadership. He has formerly been on the faculty of Oregon Health Sciences University, University of Western Ontario, that's in London, Ontario for the geographically impaired. He's been on the faculty at Dartmouth and at Brown. He developed the forensic psychiatry subspecialty residency in University of Western Ontario. That's their version of fellowship. And he was their inaugural director. He was the director of forensic psychiatric services at Dartmouth, at New Hampshire Hospital, and came to us from Rhode Island, where he was the chief medical officer for Eleanor Slater Hospital, which is the Rhode Island State Hospital, and also was the chief medical officer for the Rhode Island Mental Health Authority. In that capacity, he served as expert advisor to Governor Raimondo's Overdose Prevention and Intervention Task Force. He served as advisor to Rhode Island legislators on mental health legislation, including proposing legislation. And during his time there, he was the primary witness for the state in the case of Rhode Island versus Purdue Pharma. He is going to be talking to us about the United States community mental health system and promises me that it's going to end on an upbeat note. Dr. Daly.
Thank you, Dr. Benjamin. I will try to end on an upbeat note, as I always do. And thank you for the description of taking the department by storm. I don't know that I've ever taken a place by storm, so that's always good. So I will be talking about community mental health center system and deinstitutionalization. It's really deinstitutionalization, reinstitutionalization, which is sometimes called trans-institutionalization, and the future. That's a positive note, which I think is a good time to do this. Had I been doing this a year ago, we might not have such a positive note. I just want to start with a couple of statistics that I want people to keep in mind. So SAMHSA estimates that 5 in 10 Americans want mental health services. So that's good, right? But the US population is 331 million people. So 50% of that would be about 166 million people. And currently we see about 4.1 million people. So there's a lot of people who aren't going to be able to get care unless we do something about it. And I just want people to keep that in mind as we go through some slides. So the first slide is disclosure. I don't have any potential conflicts with this other than I'm rooting hard for us to fix things. If that's a conflict, I don't think so. I think many people here are in the same boat. Here are the learning objectives, and you have them on your survey. Describe the history of community mental health center system in the United States. Describe the history of institutionalization, deinstitutionalization in the United States. Demonstrate an understanding of the political forces that affect mental health care in the US. That's so we can all be good advocates for what will get people served, and understand the urgency of improving community-based mental health care. I jammed that one in. You only have 3 on your survey, but as I was doing this, I wanted to add the 4th one. So you have an extra assignment there for a learning objective. So well-intentioned institutionalization, that's parenthetical, but it's important because it's important to remember that when we first started putting people in institutions, hospitals, and when we built them, this was thought to be the best thing for them, and not in a cynical way. You know, I know what's best, and this is what's best for people. It really was the thing that was thought to be needed at the time. So the history of institutionalization in the United States. Prior to the 1800s, I call that the prehistory of institutionalization. There was very little organized care of the mentally ill. Most of what was done was ad hoc, so it was very variable. Towns often paid people to take care of the mentally ill in their homes, but of course there was no real oversight or real program or plan to do that. Sometimes there were makeshift county facilities. All of this was unregulated and underfunded, so you know it was ripe for abuse, and often people were kept in jails at that time. There were dangerous and unhealthy conditions. There were reports of people being kept in cages in jails and in police facilities, what police facilities there were, and in people's homes. So in the 1840s, there's an activist that I think most people have probably heard of named Dorothea Dix. Dorothea Dix was from Maine, but actually she grew up in Worcester. So this is a hometown person for those of us here in Worcester. She was initially a school teacher, and she actually had what was described, quote unquote, as a breakdown. So from the reading that I did, it looks like this was probably a major depressive episode. By that point, she had a wealthy grandmother, so she operated in sort of upper echelons of society, and she had friends who advised her to go to Europe because the mental health care here was not great. So she already knew that, why can't I get treatment in the United States? I have to go to Europe. So she did go there, and she availed herself of the experts in Europe. While she was there, her maternal grandmother died, actually, and leaving her ample resources. So that basically took care of the rest of her life from a monetary standpoint. So she was able to do what she wanted. She returned in 1840, 1841, and then she conducted a statewide investigation in Massachusetts. Basically, she was interested in seeing what we did with the mentally ill here in the United States, but she started with her home state, Massachusetts. She was greatly affected by her visit to East Cambridge Prison, where she found that the mentally ill were kept in a dank basement with little to no care, and they hadn't even really been convicted of any crimes. They were just sort of housed there because they were too ill to treat anyplace else. So she took it upon herself to write a scathing report to the Mass legislature. And she did, and indeed this impelled them to create a state mental hospital in Worcester. I'm not from these parts, but I know a lot of people know of the old Worcester Hospital because I've heard people mention it. So she went on to lobby nationally for better conditions for the mentally ill, especially living conditions. And she successfully persuaded the US government to fund the building of 32 state psychiatric hospitals across the country. And the institutional inpatient care model was considered most effective, as I said at the outset, at that time. She had seen this in Europe because they did have institutions already underway in Europe, and it led her to understand that it was a place where people could get coordinated care and get care together. So you could sort of have everything in one place. When these institutions were built, they were actually welcomed by families who were struggling to care for the mentally ill. And this was not really new. And the oldest example is Bethlehem Royal Psychiatric Hospital in London, 1247. I was surprised that it was that far before us. And of course, you might know Bethlehem because it gave birth to the description Bedlam. That's where that comes from. So the model had been developing in Europe. Hospitals increased patient access to mental health services. They could be consolidated in one place and services could be delivered to the greatest number of people. So that was the great benefit. But also there was great housing benefit, right? Because people had sort of makeshift existence at the time. The thinking that was being used was mostly some psychiatrists who I've listed here, just so you have the names in your head. Betty and Luke from England, Pinel and Esquinal from France, and Chiarugi from Italy. Sorry, my Italian is not very good. And the phrase moral therapy started to be used in Europe around this time, leading into the 1800s. And so that was borrowed in the United States. Asylums had been greatly expanding knowledge as well. That's an important point. So people were learning about psychiatric illness because of institutions, right? They were able to observe longitudinally, see the natural course of illness, have a better understanding of what a diagnosis might be. And so there's a great advancement in the field at the time. So psychiatric hospital expansion. After Dorothea Dix took to the road, there's great expansion of institutions in the United States. This occurs over the next 40 years from the 1840s on. Dix herself helped found and expand 30 institutions. And I believe the hospital in Maine is still named after her. In the late 1800s, chronic, quote unquote, chronic patients moved from county facilities to the new state facilities. This was mostly to save money. Chronic at the time meant chronic psychiatric diagnosis, which we've come to understand, mostly things that didn't wax and wane. But there were also things like epilepsy, dementia, and neurosyphilis. Elderly population was growing in the 1800s, and this was because lifespan was improving because of general medical care. And so many demented people were also transitioned to the hospital. The greatest expansion occurred in the last part of the 19th century. That's mostly because facilities were being completed and built by then. So 1880s, 1890s. The county facility started sending patients to unburden county costs to the state, since the federal government was helping to pay for things at the time. Institutions grew rapidly in the last 15 years of the 1800s. And I have here, just as an example, Oregon State Hospital. As you heard at the outset, I was at OHSU, and I was actually at the hospital and got to visit, not the unit where the movie was filmed, but people will know this from One Flew Over the Cuckoo's Nest. But it serves as a good example because it was one of the most rapidly expanding hospitals in the country. So in 1880, Oregon State Hospital and affiliates, there were a few hospitals, had 412 patients. By 1898, they had 1,200 patients. So imagine growing 788 patients, trebling your census in just 20 years. So that's something significant right there. And you can sort of see that on the graph there. It's a little difficult to see, but I just put it on there so you can basically see the trend line of the curve. And of course, the picture of Jack Nicholson in the movie. I couldn't get a clean one of just the hospital, so you get Jack Nicholson for free. And I'm sorry, more generally, as time went on through the late 1800s and early 19th century, 20th century, 1900s, there was continued expansion. By 1955, there were 550,000 people in hospitals in the United States. Some states created multiple smaller hospitals, other large state hospitals. It's important to remember that compared to what existed before, this was actually something of an improvement. They were not without problems, though. So as the years went by, there was notoriety of most of the state institutions, especially as we came into the 20th century. State hospitals were often underfunded, even from the start. This became profound during the Great Depression, right? So as states were scrambling for funds and money, and everybody was doing fairly poorly, of course, state hospitals did poorly as well as funds were diverted. There was lower staffing, worse facilities, and of course, that always leads to worse care. There started to be developing harsh criticism of the treatment that people were receiving. And they were not exactly bastions of good science. So the picture that I have here is, of course, an insulin therapy. Insulin shock therapy proliferated in state hospitals at the time. This is also the time of the proliferation of lobotomies, as we know in our field, that were occurring in state hospitals. There was a psychiatrist in New Jersey who thought that and it was a New Jersey State Hospital, he thought that all psychiatric illness was due to infections. And so he took to taking out people's teeth and tonsils regularly. And there were even some reported cases of him removing spleens and ovaries because they were thought to be sites of infection that caused psychiatric illness. And this is happening in a state hospital. So there was little oversight. And of course, people just did what they thought was good science, off the top of their head. This is also the era of eugenics. And this was seen in some of these facilities. So there was basically eugenics was an effort to stop reproduction of the mentally ill. In 1896, Connecticut became the first state to prohibit marriage for people that they thought ought not to procreate. And included in that were epileptics, imbeciles, and the feeble-minded. That's written in the law at the time. And of course, this was also the time of sterilizations. Sterilizations and sterilizing the mentally ill was an issue that made it to the United States Supreme Court. It was a case of United States Supreme Court case Buck versus Bell. And Oliver Wendell Holmes was justice at the time. Oliver Wendell Holmes, writing about sterilization in the decision, wrote, 3 generations of imbeciles is enough. So eugenics, although thought to be a treatment for the mentally ill, strangely, it was targeted at people who you would expect this to happen, right? So immigrants, people of color, the poor, unmarried mothers, and the disabled. By the early 20th century, these institutions provided merely custodial care. And I put this picture up because I thought it was a nice sort of combination of some of what I'm talking about. The idyllic versus the not so idyllic, right? So here is a nice drawing of the New York hospital, right? It looks great. People are there. They're visiting family. The hospital looks great. And of course, the name of the place is the lunatic asylum, right? Because that was thought to be something that was appropriate at the time. The one important thing to remember about the New York State Hospital was it became the home to moral treatment, even though it was called a lunatic asylum. This was brought over from Europe. And part of moral treatment was thought that people would do things that were normal. What they wanted to do is have people emulate what quote unquote normal people did in their lives. So they thought that one of the big things that people did was work. And they had people work at the hospital. They had people grow food for the hospital, but there were abuses. Some of the staff would take patients home to work on their homes and things like that. So deinstitutionalization. All of this, all of the troubles and the notoriety and the bad things that were happening in hospitals start to be realized as not appropriate treatment. And so people start pushing for deinstitutionalization. This is especially true from the Depression to the 1950s. And there's a push for deinstitutionalization. Several things happened to start the ball rolling. So the first of these things is World War II. Soldiers are returning from war, and they actually are demonstrating significant mental illness. There's an estimate that 1.75 million people needed treatment. This would have probably been the precursor to what we know as post-traumatic stress disorder. I think in World War II, it was called shell shock. So the general public now was developing more of a conscience. While the stories about the institutions were proliferating, people didn't want that to happen to veterans who had fought in World War II. In 1946, there's the National Mental Health Act, and this creates the NIMH. This is important because it is the federal government saying that they're going to play a more significant role in the treatment of the mentally ill. NIMH was envisioned as being a place to develop the best practices in thinking to help inform the field. By the 1950s, there was the development of antipsychotic drugs. People generally know the history of Thorazine, and that started to be used in the 1950s, which also contributes to the push for deinstitutionalization. All of this led to great optimism and hope. People thought that we could facilitate outpatient treatment. People start thinking, well, if you have medications, you can treat people outside of an institution, can't you? Medications ought to be able to control symptoms. They can manage people in the community. And there were a lot of people who thought that this would be a potential cure for most mental illnesses. At the same time, there was an international movement away from asylum-based mental health care and toward community-oriented care, especially in Europe. Psychiatric patients were thought that they would do better in the communities. And of course, modern medicine started to think that the mentally ill were not just people to be put away, but actually people who could benefit from treatment. ECT started to become prominent in the early 20th century. And that was having great results, as it continues to do for certain illnesses. And antipsychotics were proving effective. Many people began to ask, can't we take people out of institutions and put them into the community? And because of all of these advances and problems with institutions, this was basically the impetus for this. So there's a movement to treat patients in the community. New York State developed a Mental Health Act of 1954. It's the first one of its kind in the country. It funded clinics and therapy, but also medications. New York recognized that perhaps the best treatment would be medications and therapy. So deinstitutionalization begins in New York, and it really starts to take hold in the 1950s, mostly in 1955, as people really begin to start to move toward the belief, at least, if not the actual doing of moving people out of institutions. Other states began to follow New York, though there was a sort of a mixed bag of results and plans. Some states were somewhat opportunistic, and they just took the opportunity to take people out of institutions without any sort of real plan. California actually mandated that families had to pay once they took people out of institutions. By the 1960s, there was great disparity across the states, and many people were calling for the federal government to intercede. And intercede they did. So the Mental Health Center Construction Act in 1963. So I have this picture here because I think that it demonstrates, well, first of all, it's President Kennedy actually signing the act. So that's why that's there. But the family is there because a lot of people talk about President Kennedy having a special spot for the mentally ill because he had it in his family. His sister Rosemary was thought to have mild developmental disability as a child. And this is his closest sibling in age. She was only 14 months younger than him. She became difficult to manage as a teen. She was known to be an embarrassment to the family, and some of the family thought that. And the father actually had her lobotomized when she was older. This left her greatly impaired, and she was left in an institution thereafter. Most people say the father never visited her again. But many people say that this is why treatment of the mentally ill and improvement of treatment of the mentally ill was something that always aided President Kennedy. And I have this quote here. I'll read through it. I usually don't put lengthy quotes in a presentation like this, but I just thought it was sort of captured the thinking at the time. I'm proposing a new approach to mental illness and to mental retardation. This approach is designed in large measure to use federal resources to stimulate state, local, and private action. When carried out, reliance on the cold mercy of custodial isolation will be supplanted by the open warmth of community concern and capability. Emphasis on prevention, treatment, and rehabilitation will be substituted for a desultory interest in confining patients in an institution to wither away. And I think that one of the key things about this quote is that it calls out institutionalization. It starts to be the talking of institutionalization as being a bad thing. That was a movement in the country at the time, but certainly the president captured it. And I think that's important. So there was a plan actually to create community mental health center system in the United States. And this is Kennedy's plan. The plan was $150 million to construct CMHCs. Federal government will pay between 1/3 and 2/3 of the cost. And they said there's things you have to do. So this is one of the first times that the government says things go haywire when we don't have oversight and regulation. So there's things that you have to do. It was thought that this was a way to incentivize better care, but also to save money. If the government was chipping in, states wouldn't be on the hook for the whole kit and caboodle of paying for patients. So this was shared responsibility. And what was mandated was you had to offer inpatient care, outpatient care, partial hospitalization, 24-hour emergency services. So this seems like what we do now, right? In 1963. It was an impressive array of services. And one of the things it established was actually a catchment area for CMHCs. The plan was supposed to give responsibility to a community mental health center system for the people in its area. You had to take care of everybody there that was mentally ill. And you're supposed to take care of everybody that was mentally ill. The plan called for 2,000 CMHCs by 1980. And the hope was to make state hospitals obsolete. Sounds perfect. What could go wrong? So there are some beliefs underlying it that were the beginning of the problems of the CMHC system as it unfolded. It starts with the psychiatrists who helped to formulate the plan. These are the psychiatrists here, their names, Robert Felix, Stanley Yalls, and Bertram Brown. These are psychiatrists who informed the president and they advised on the creation of the plan. It was basically their brainchild. What they thought was that you could move virtually everybody out of hospitals and they could be treated in the community. They thought they had a lost chance, though. They did not involve state mental health directors. And so what really happened was they didn't have a good understanding of patients that were still left in state hospitals at the time and what their needs might be. So their thinking was that fewer people would need to be treated because they thought that medications and therapy would actually prevent mental illness. So they figured that if we create mental health center systems, even the number of people who are in hospitals will be less as they're in the community. And of course, we know that didn't happen. Shortly after that, the federal government goes all in the plan to deinstitutionalize patients and to do away with institutions. And this happened on several fronts. So in 1965, the CMS Act was created, Centers for Medicare and Medicaid. Included in this is a very important part right from the get-go, the IMD inclusion. Have people heard of the IMD mix, the IMD inclusion? And exclusion. So IMD stands for Institute of Mental Disease. And in the creation of CMS, they actually put in the legislation that we will not pay for a place to be an IMD, an Institute of Mental Disease. They didn't want to have people institutionalized. So they recognized that they were a funder and they couldn't pass state law, but they did what funders do, right? They said, well, okay, you can do what you want, but we're not going to pay you for it. So they said, you cannot be an Institute of Mental Disease. You will be one if you have more than 16 people in an institution. Big hospitals did push back and say, wait, we have 30, but that's not our primary goal. Our primary job is to treat medical patients. So they said, okay, 16 beds, but if your primary business is not treating the mentally ill, you're not an IMD. So this was called the IMD exclusion. You were excluded from billing Medicaid if you had more than 16 patients and they were institutionalized. And that's the IMD exclusion. You can apply for an IMD waiver now. It's usually just a sort of rote thing that big hospitals like UMass does. But from the get-go, from the creation of the CMS Act, they're saying, we are also going to prevent institutionalization. By the mid-1960s, the US had many severely ill people had been moved from psychiatric hospitals into the local communities. And over the years, the number of institutionalized mentally ill patients fell from its peak of 560,000 in the 1950s to 130,000 by the 1980s. And by 2000, the number of state psychiatric hospital beds per 100,000 people was 22, down from 339 in 1955. So this was really sort of the great deinstitutionalization of people from 1955 on. And this chart here I thought was nice because it just shows the first year is 1970, and it shows the different types of hospitals you have, or the different types of places where people could be housed. So even by 1970, the number is down a good bit. All facilities are 524,000. Just a little while ago, I told you that 560,000 were in state hospitals in 1955. So already there's a significant drop. And these are all the rest of facilities. So the top bar is residential. And it was mostly makeshift residential as people got discharged, and I'll talk about that in a little bit. The next bar is Veterans Administration in the tall bar. So as you can see, the Veterans Administration goes down over the years. The next bar is psychiatric units in general hospitals. That sort of goes up and then down. Then there's private psychiatric hospitals, minimal in 1970, that sort of expands. And then of course, state and county hospitals still continues its precipitous decline. That's the lower dark bar. So as you see over the years from 1970 to 2002, especially 70 to 76 and then 80, there's a significant drop. So what happened? Well, the CMHC Act was underfunded from the start. Initial funding structure had states pay more and more as the years went by. And if you recall, even at the outset, it was only going to be 1/3 to 2/3. Recall also that the Great Depression had happened, so people were strapped by those things. Clearly, the number of mentally ill did not decrease, as we know. Obviously, prevention didn't work. There were more people who needed to be treated as time went on. They had not properly considered the people who were in hospitals who would further be deinstitutionalized because who was left in hospitals after the introduction of antipsychotics? People who were refractory, and these people were deinstitutionalized to community mental health center systems. And then through the late 60s and early 70s, there were significant things that increased the number of people needing treatment. The Vietnam War happened. There was economic decline in the country, especially in the 70s. There was greatly increased drug use as heroin became quite predominant. And so the numbers needed to have care increased, and there were no longer state hospital beds being offered to them. What happened continued. Much of this was what the federal government wanted to do, right? Not necessarily poor treatment and not necessarily people not getting treatment, but deinstitutionalizing hospitals. To further this, Medicare actually started to say that you can't treat the elderly in hospitals. They need to be treated in nursing homes, and that's what we're going to pay for. The IMD that I explained before came to be more rigorously enforced as years went on. States had budget problems in the 70s, mostly due to social issues that I just discussed. And this greatly affected state hospital budgets. And the quality of care at state hospitals deteriorates as it does when you lose funding. So at the same time, mental health laws were becoming dangerousness-based. So hospitals were even unable to admit people into some of the beds that they had. Adding to the number needed to be managed outpatient, right? So these are patients that are not getting into the hospital. They need to be treated in the community. In 1975, there's a U.S. Supreme Court case, O'Connor versus Donaldson, that finds that people deemed to be a danger people who are not deemed to be a danger to themselves cannot be committed, right? So now you have a dangerous space for committing to a hospital. And shortly thereafter, there's a California case, Tarasoff v. the Regents of California. I think most people know this. This is the case that developed the duty of a psychiatrist to protect. So now psychiatrists have to be in the business of protecting others. And so who goes to a hospital? People who are generally dangerous. This means that there are sicker people in the community. And by 1980, only 754 of the proposed 2,000 CMHCs had been created. All these things created burdens on the CMHCs. So there was more demand and less money. And in 1980, what I call the final nail for the CMHC system happened. This was the 1981 Omnibus Budget Reconciliation Bill that President Reagan signed. So it raised defense spending and it slashed domestic programs, basically, is the thing to know about it. One of the costs that were cut deeply were CMHCs. And wide discretion was given to the states on how to spend the money that was formerly for CMHCs. So states could start using them for other things. And indeed, that's what they did. The important thing to know about this is that it didn't necessarily contribute too much to the deinstitutionalization, but it happened at the time when deinstitutionalization had basically almost finished. And so what you have is the federal government getting behind deinstitutionalizing people. And then you have this bill cutting the CMHCs. So the CMHCs were supposed to be taking care of them and they couldn't anymore. So the timing was terrible. And indeed, the federal, as Tom Insel, a psychiatrist, said, the federal government basically checked out in 1980 and no longer became involved in how people were treated. And I think this graph sort of shows that, and it's the reason why I wanted to have it up here. So this runs from 1950 to 1995, so it doesn't come up to the present day. You can see the peak up there was a 560,000 in 1955, first antipsychotic drugs. Then there's a gradual decline in the slope. Probably mostly due to some deinstitutionalization movement, but also because of antipsychotic drugs. And then there's a precipitous decline, right? From 1965, Medicaid and Medicare enacted on. So with the full weight of the federal government behind it, look at how steep this slope is, right? And so this is deinstitutionalization. Now remember, the plan didn't, and the psychiatrists who advised on the plan didn't really take account of the people who were left in the hospital. So if you put together those two slopes, what's left? People who didn't respond to antipsychotics, certainly a large portion of them are deinstitutionalized to community mental health center systems. And from 1980 on, you can see that's when the omnibus bill was enacted. Of course, the slope isn't that big because there wasn't too much more deinstitutionalization to be done, but that's where it had already been done. And look, the community mental health center systems have been cut deeply. What happened to the people? Patients did not get care at community mental health center systems or community mental health centers. They found it difficult to even live. Now, remember, they'd been in hospitals, so people had been doing their cooking, their cleaning, occupational tasks for them. They had been basically institutionalized. Halfway houses proliferated. Many were run by ex-hospital employees. They were in the poorest neighborhoods because of costs and because of NIMBY, right? Not in my backyard. Horror stories abound. Patients who were interviewed at the time reported significant loneliness, poverty, bad living conditions, and poor physical health. And psychiatry played its part. Most CMHCs were actually a psychoanalytic psychotherapy base. And so people were transitioned to them from hospitals, and the psychiatrists at the time were ill-equipped to take care of the refractory illness that they were seeing. Not that they necessarily didn't want to, but were unable. So imagine the flooding of outpatient practices that took place. And of course, by the end of deinstitutionalization and in the ensuing years, only 10% of the people who had been in state hospitals were ever seen at a community mental health center. So this leads to reinstitutionalization. So here are some outcomes over the decades. Homelessness among schizophrenics proliferates. We have become a country that keeps its SPMI in the streets, even now. The 90% that didn't make it to CMHCs largely had terrible social circumstances, including homelessness. And we created what has been called a, quote, indigent underclass of the mentally ill. There was variable success of the CMHCs. Few CMHCs were able to demonstrate significant success in all required measures. Many did poorly. Many more patients than could be cared for actually made it to the CMHCs. So they were in the community. That is especially true when you examine the catchment area issue. Even the CMHCs that did well would generally look at the patients they saw and say, this is how we do with these patients. Well, that's fine but if you're taking care of 5% of the people who need to be taken care of, and you're not counting the other 95%, how good are you doing, especially since you were supposed to take care of a whole catchment area? There's poor health measures in general. This includes medical and physical health, and there's poor integration of care. Dangerousness criteria ensured fewer people could be admitted to the hospital at the same time. So even the patients that they were seeing, if they became difficult to manage, hospitals were no longer needed. Earlier, hospitals had been based on an in need of treatment sort of model before dangerousness became a thing. So if doctors thought people could benefit from treatment, they would go to the hospital. Obviously, there were abuses of that sort of criteria as well. So now there's much higher acuity in the community. Crowding starts to take place, and there's revolving doors in hospitals that are able to see people because there's much fewer places for them to go. As years went on, insurance companies started to proliferate, and certainly that's a problem now. Insurance companies want people out of the hospital as quickly as possible. So this contributes to the inability to take care of the most ill that are being seen in the community. And even when people are admitted, they're discharged quickly. So creating an indigent underclass of the mentally ill was not inevitable. Studies from Europe show that if people are given some basic things, and these are mostly social things, they do quite well. And the things are housing, aftercare, a support network, and jobs. The initial CMHC plan underestimated the needs for those things. While they sort of emphasized to a certain extent whole person care, social determinants of health certainly wasn't known at that time. And states are unable or unwilling to take up the slack. Trans-institutionalization is a type of institutionalization. It generally refers to people being housed in jails and prisons. This indeed becomes a problem with people who are not being seen by anybody and who used to be in state hospitals. At least 1/5 of all prisoners in the United States have a mental illness. Over 25% of those with a serious mental illness, depending on how you define it, will be incarcerated at some point in their life. The 3 largest mental health care facilities in the United States are Cook County Jail, Los Angeles County Jail, and Rikers Island, New York, in that order. State hospitals are becoming mostly forensic. This is certainly the case over the past 15 years and continues now. Several factors have led to this: higher acuity in the community. Police often report that forensic admission is the best option for treating people. Judges are increasingly remanding misdemeanants. They know that they'll get the care that they need, that they didn't get in the community in a forensic setting. Misdemeanants, do people know what I mean by that? So a misdemeanor is a lower level crime, a crime for which if you are not mentally ill, you just get a year or less. And if you are not mentally ill and you've committed a misdemeanor, unless you have a long record, you usually get bail. But now what judges do is they actually remand people with mental illness, even for the same crime that you would get bail for. So the only reason that people are incarcerated, and it's usually for restoration of competence or usually incompetent to stand trial, is because they have a mental illness. And of course, that's the case now here in Massachusetts. So at our own Worcester Recovery Center, 10 years ago, it was less than 50% forensic. And so the rest of it was treating seriously mentally ill. Now it's over 80% forensic. And we think that in the next 3 to 5 years, it will be 100% forensic. The near future, there's a tsunami wave cresting. As baby boomers age and natural dementia epidemiology takes hold, those people are going to overwhelm the system, including the forensic system. What happens is people commit a crime and they are not competent to stand trial because of dementia. And so they're usually pre-trial and held in state hospitals. If it's a serious crime, you can stay as long as your sentence might be if you were found guilty pre-trial in most places in the United States. And of course, the opioid epidemic continues. Anxiety and depression are on the rise from the pandemic, the COVID pandemic. And an interesting fact, the US suicide rate has increased by 30% since 2000. I haven't found people who can get a good handle on why that's the case, especially when peer nations are down 18%. But certainly it's something that's going to contribute to the need for people to have care someplace going forward. And of course, coupled with the baby boomers, that's going to be an issue that overwhelms the system unless we do something. So the future is all hope lost. Dr. Benjamin wanted me to end on a positive note, so we'll start getting into the positivity now. There's been a lot of negativity, so everybody take a deep breath. No, all hope is not lost. Because we're going to try again. We're going to get it right this time. I know we said that before, but we're going to do it this time. So the way we're going to get it right is something called the Safer Communities Act. It's known as the Gun Act. I was a little surprised at how little notoriety this part of the Safer Communities Act or the Gun Act got, because it's creating a whole new system that's what the other system was supposed to do. $10 billion via Medicaid is going to be used to create certified community behavioral health clinics. They're supposed to deliver whole person care, evidence-based approaches, and both of those things demonstrate that we've learned lessons from the past, right? You got to take care of the whole person, including social determinants of health, and you got to use evidence. So that's a good thing. How is it going to unfold? Section 110001 of the Act is where you find the specifics about the CBHC system. CMS is awarding planning grants. States are going to develop proposals. 10 states will be chosen from those proposals to launch in July 2024, and every 2 years, 10 more states will be chosen. So we could conceivably get all states done by 2030. They want to see several things done as part of any state plan. Increased access is vitally important, and everybody writing about the law says we recognize that people didn't have access. We recognize that we didn't do catchment areas. We recognize that there was an enormous amount of people who weren't cared for. Must have robust behavioral health urgent care as part of the plan. Telehealth is going to be used, so we learned from the pandemic, and it's going to be used widely and to help with access. Awareness programs like Mental Health First need to be implemented, and suicide prevention incentives need to be undertaken by any state that wants to develop a CBHC. So what's going to be the difference? Well, we've learned from our past failures, at least it seems from everything that's written about the bill. We know why they didn't work and what the consequences of failure were, at least to a certain extent. We have more data now that's from ourselves and other countries. And it seems like they have heard all this and incorporated a lot of it into what's required to become a certified community behavioral health clinic. Social determinants of health are prominently mentioned. The data is clear that what matters most in taking care of people, and this includes medical diagnoses as well. It's not so much how often people see the doctor. It's not so much what the doctor does. What matters most to people's care is where you live, how you live, and who you live with. Tom Insel said that. CMHCs and CCBHCs are the least expensive alternatives, especially when you consider everything like disability costs, emergency care, inpatient care that could be prevented, and of course, crimes, etc. There's a bipartisan nature, so that should help. It was written by a Democrat from Connecticut and a Republican from Texas. And California is already setting a good example. They had this ready to go and they're launching their plan in July of this year. And it does three important things. They're actually using their Medicaid money and they've gotten permission from CMS to do a few things, including write prescriptions for food and housing. So they're going to use their money to make sure that people get food and get housed. Obviously, they're recognizing the importance of social determinants of health. The second thing they're going to do is they're focusing upstream from urgent care, which I think is different from the CBHC plan, I think is important. They are implementing a plan where you don't even have to have a mental health diagnosis to access care. You could be telling your primary care doctor that you think you might have problems. You don't have to have a diagnosis, and California is going to pay for you to see a mental health professional. So here's your prevention that people talked about all along. And the third thing that they're doing is investing heavily in the 998 program. I know this was launched nationally over the summer. Again, I didn't hear a lot about it. 988 program is supposed to be the like 911 for the mentally ill, right? So the problem with 911 for the mentally ill is that it deploys police officers. And when I used to do training for police officers when I was in New Hampshire, I used to tell them at the outset, you know, you're going to see more people in your career, more mentally ill than I will. And they'd be stunned, any street police officer, and they will. And so this is supposed to be set up to deploy mental health people to see people in the community, mental health professionals, rather than police officers. And this is important because people with severe and persistent mental illness are 16 times more likely to be shot by a police officer. Massachusetts launched a CBHC at the same time. This stands for Community Behavioral Health Center, not clinic. Massachusetts seems to have a habit of taking something and renaming it and calling it its own. So this is it, and it's started already. We're supposed to launch in January, those places that have been awarded a CBHC grant, and Community Healthlink is one of them. So we're starting in January, or we're supposed to. I'm looking at Yale because we talk about this regularly on Zoom meetings, whether we'll be able to do it or not. And there are key goals, right? But here again, this is borrowed from the plan, although Massachusetts was starting this before that was released. Expanded access is key. They understand that people need to be treated. Focus on equity through cultural competence. This is another big thing that Massachusetts is doing that I didn't see in the national plan. Evidence-based, goal-oriented, trauma-informed care. Coverage throughout the Commonwealth for all ages. Community-based crisis intervention. I like the California model where you focus upstream. Massachusetts is putting a lot of eggs in the focus on urgent care basket. So that could be good, but boy, that California idea seems pretty good to me. But of course, California has a budget surplus, so they can also throw in some of their own money. And significant new funding, and you have to show metrics and be accountable. The state is emphasizing increased access, of course, and they have a front door process where they're going to get everybody into the system. Potential roadblocks. Some argue that institutionalization is better than we have, right? And the people who say that say, well, we've done this. We've done the community and it didn't work. People did poorly. They're homeless. They're in jails. So what are you talking about? You still want to focus on a community system and rather than hospital beds. We need more hospital beds. That's where people get taken care of. They particularly say this because they can point to hospitals are much better now. You're comparing it to a time when they used to use lobotomies. We have evidence-based approaches now. We have much more medication. We have lots of other things. People who counter this point to the fact that there's not a lot of overlap between the people who end up in jails and prisons and those who end up in hospitals. I think that used to be more true about 15 years ago, but actually as misdemeanors get put in hospitals more often, I think there's greater overlap. I've worked acute inpatient units in forensic and in hospitals, and it's the same people. It's the same illnesses. It's just one of them happened to get arrested and one didn't. And sometimes that's because they know that they're going to get treatment that way. Politics can play its role. Funding can be stopped anytime. Could we have another omnibus budget act that's going to slash funding? Hopefully the fact that it's bipartisan will take care of that, but we'll see. Another war on drugs, increasing the number of mentally ill. That could happen. And the public and even politics jump on the bandwagon every time there's a mass shooting, and this is the United States, so I'm sure we're going to have another mass shooting sometime, that these people are mentally ill and need to be put away in state hospitals. And the fact that we don't have beds for them is the reason these shootings happen. Certainly, analysis of these cases doesn't bear that out, but of course, that's what gets play in the media, and that's what people in the media report. There's a very cynical view that some people have, trans-institutionalization. It's cheaper. It's cheaper to take care of these people in jails and give them mental health care there than it is to create a hospital or community mental health centers. And the only thing that I would add is I think both of these plans, the federal and Massachusetts, need to have a more whole system approach. As a forensic psychiatrist, I can tell you that you need to pay attention to the forensic population because they are becoming criminalized because they're ill and they're getting treatment in forensic facilities, and sometimes better treatment because you can keep them there more longitudinally. So it's important to recognize this, and it's important to consider as part of the system their deinstitutionalization, because we shouldn't have people who commit loitering serving 6, 7, 8 months in jail while they are pre-trial and restored to competence. You can restore people to competence in the community. And that's it. These are recommended readings I think I have for you to look at. The first one is actually a great podcast of the psychiatrist Tom Insel on the Ezra Klein Show. And so I strongly advise people to give a listen to that. And all the others are just general overviews. There's a nice article in the Atlantic, etc.
Thanks very much, Dr. Daly. We have just a few minutes, but we have a lot of questions. So first of all, people in the room with questions for Dr. Daly? Go ahead, Dr. Harrington.
Well, I was just wondering about the workforce issue, because I think you can create all these programs, but if you don't have qualified people to work in them, they're not going to succeed. So are we doing the right things to increase our workforce?
Yeah, so the funding is supposed to help with that, right? So you're supposed to be able to increase pay for people. Will it work? It remains to be seen. But that's what's happening in Massachusetts. So the CBHC plan here actually has enhanced rates. And so if your reimbursement is higher, theoretically, you're supposed to be able to pay people more. Now, the problem in Massachusetts that I'm seeing boots on the ground is, well, give me the money first to hire the people. Like, how can I generate the income that's going to be needed? I'm probably loud enough. How can I, and if you give me this, I'm going to be like Barry Manilow.
Okay, just for the Zoom people.
Oh, I'm sorry. How can you expect me to hire the people before you give me the money when, you know, I need to generate the income? I need the people. I don't know, you know.
So there's lots of good questions online. First, a comment by one of the over 75 people who've been out there in the Zoom audience, just reminding all of us that when we talk about subjects like this, that we remember to refer to people as people rather than as diagnoses. And we all have to always remember that. Here's a good one. Question for you. Do you think that outpatient commitment is an effective solution? And I'm going to put in parentheses there. What do you think about the city of New York, about the mayor of New York's solution? But save that and tell us about outpatient commitment.
So I do believe, and I think the evidence shows that outpatient commitment is a solution. If you mean a solution in terms of this, I mean, it's a solution to keep people out of the hospital. There's no question that long-acting injectables keep people out of the hospital and do well. And so the states that make people have them as part of their mental health law keep people out of the hospital better. Now, that said, the New York plan seems idiotic because the little I read about it suggests that I don't know who's evaluating people and calling them mentally ill to commit them. They're taking people on the street. What mental illnesses, what diagnoses are you talking about? And this is good because they're people, right? So if somebody says the wrong thing, are you going to scoop them up? I mean, if you think they have schizophrenia, and it's who's making the diagnosis. So I don't think that that's a very good plan, at least from what I've seen of it. You know, I haven't read deeply into it.
Boy, this discussion is worthy of another half hour. And let me just let another question or to go through. Dr. Rizzi asks a very interesting question that I hadn't thought of. What about the for-profit corporations that run incarceration facilities? Are they going to hoover up this money in some way that should be, different purpose?
Well, if they run inpatient, they probably shouldn't, because this is going to be earmarked for outpatient. Let me be clear. The new federal plan is squarely in the house of, you're not going to institutionalize people. And again, so this is community now. So if private entities are running hospitals, probably not able to hoover up the money. Now, would this make them start to be outpatient facilities? Maybe. I mean, we have private CMHCs, so possibly, but hopefully the oversight will continue. The evidence base, holding people's feet to the fire, making them adhere to standards, hopefully that will continue.
Okay. Let me let one more through. There's quite a few more, and I'm going to encourage people to email Dr. Daly.
Oh boy, I have time
with questions if they would like to. But try this one, which I think is very interesting as well. Are there any plans that you know of to increase the forensic training or the forensic staffing at CMHCs at that level to address the increase in clients with legal issues coming out of institutions?
There are no plans. And if I was watching the clock and I couldn't go into the Daly Addendum as much as I wanted to. So if I had my way, I would create forensic fact teams, marry them to community mental health centers, restore people to competence in the community, and there have your forensic people. So you do just what you do with an ACT team, except you're reporting to court. Your Honor, the social worker goes into court. Your Honor, John is not doing too well. He needs to be put into the hospital. Okay, but at least you're keeping some people out, right? You're not remanding them. They're not being seen in a hospital. And by the way, most states have the evaluation for competence done at a hospital. So the judge sees them and says, send them back there. The other thing to do about that is have doctors in courts do it on the spot, court clinics. You do the evaluation there and you put your evidence in testimony. You get on the stand and you say the person is competent, Your Honor, in my opinion.
Okay. Thank you very much, Dr. Daly. It's a very provocative and timely discussion.
Thank you.